Hey guys, welcome back. This is ECG Primer 2, Bradycardias. But before we dive into the bradycardias, I do want to do a bit of a review of what we covered in the previous session because I know it's a little bit of a different way of thinking for most people. So I really want to reinforce it and have it down pat before we go into various arrhythmias. So a bit of a review. Again, the relative positions of the LV in relation to the RV. The RV sits in the front, bulges towards the chest wall and goes almost vertically down, versus the LV curves away towards the apex, towards the side of the chest, and is oriented on the left and down direction. So if we superimpose those two vectors, we'll end up that the average heart, the overall vector of depolarization, the direction of electricity is down and left somewhere between these two vectors. So what does that mean? Well, remember that the vectors of depolarization are simply a reflection of where the muscle mass is and how the charge within the muscle mass is changing. So if we look at the LV, which is pointing kind of diagonally leftwards and down, that is going to be the overall vector of depolarization of the LV. And if we look at the RV, we said it's pointing almost vertically downwards. So the overall vector of depolarization is going to be essentially down. Again, remember that we can combine vectors and break them down into component parts. And if we combine these two vectors together, we'll end up in an arrow that's slightly between the two of them, so slight bit more downwards than where the LV is going. And majority of the deflection is going to be caused by what the LV is doing, by the simple fact that the majority of the muscle mass is sitting on the left. If we add the third dimension, then we will see that the RV pulls the vector towards the front of the chest wall, which is measured by the leads V1 and V6, and the LV pulls it towards the apex, which is where most of its muscle mass is, and that's vectors V5 and V6. And then just a reminder as to how the electricity gets conducted. The origin of most of the impulses is in the SA node, travels down very quickly to the AV node, and then the AV node conducts the impulse quite slowly using diffusion of calcium ions, which induces the PR segment, or at least most of it, and then the signal gets quickly transported into the ventricle using the two fascicles, the anterior and the posterior fascicles on the left, and the single fascicle on the right. So let's try to work out the axis of this EKG. So lead 1 is positive, so we know the electricity is going towards the left. Lead 2 is wholly positive, versus lead AVL has some negative deflections there. It's a little bit tough to say, but there is no negative deflections at all on 2, so electricity is going downwards, and we confirm that by looking at the lead AVF, which is positive. So it looks like the electricity is going just leftwards and slightly below the horizon, and at about 90 degrees compared to lead 3, because the lead 3 is isoelectric. So left and slightly down, a left dominant axis. And then in 3D, if we look, leads V1 and V2 are predominantly negative, V5 and V6 are predominantly positive. So most of the electricity is going towards the apex and towards the LV. So again, it's a left dominant axis on both 2D and 3D. And again, just a review as to the why. Let's look at this one. Lead 1 is isoelectric, so we know electricity is going perpendicular to it, so either straight up or straight down. We'll compare leads 2 to AVL. Lead 2 is strongly positive, AVL is quite negative, so we know it's going down, which would mean that AVF would be positive strongly, and it is, and 3 is quite positive as well. There is very little difference between in the positive deflections, in the amount of positive deflection between leads 2, 3, and AVF, which means the electricity is going pretty much straight down, which is a little bit more rightwards than is in an average heart, but it's still in the realm of normal axis. And then if we look at 3D, V1 is almost wholly negative, V2 is still mostly negative, V5, V6 strongly positive. So again, it's a left dominant heart in 3D. Electricity is going towards the apex rather than towards the front of the chest wall. And again, just an explanation and confirmation of the why. Let's look at this one and we'll add tests for hypertrophy and block. Lead 1 is positive, electricity is going leftwards. AVL is more positive than 2, so it's going left and up. AVF is almost isoelectric, so we know electricity is going now leftwards and just slightly above the horizon. And in 3D, V5, V6 strongly positive, V1, V2 strongly negative. So again, left dominant axis in both 2D and 3D, so normal. But if we look at hypertrophy, we'll see that AVL is bigger than 11 millimeters. We'll see that V6, for example, is bigger than 5 boxes. We'll see that V6 positive deflections added to the negative deflections of V1 adds up to more than 7 millimeters. So we recognize that this is left ventricular hypertrophy. And again, this is the explanation as to the why. How about this one? Lead 1 is positive. Electricity is going leftwards. AVL is positive while 2 is negative. So electricity is going strongly left and up. We confirmed that by looking at lead AVF, which is wholly negative, and lead 3, which is even more negative. So we do know that this is going quite a bit upwards. So this is a left axis deviation. If we look at 3D, it kind of looks funny, and I'll cover this in more details in the course. I don't want to confuse you at this point in time, but V1 and V2 are wholly negative, and V6 is somewhat positive, so it is still a left dominant axis. And as for hypertrophy, the only sign that we have of it is that AVL is more than 11 millimeters, and we said that is the most specific sign. So in this case, we have a strong left axis deviation, left and up, and some signs of hypertrophy. So what's going on here is a left anterior fascicular block. Now remember, we said with a left anterior fascicular block, which stays to the top of the LV, the electricity gets conducted quickly down the posterior fascicle, and then from there it travels in the left and upwards direction. And that is probably in this particular case because of hypertrophy, which has infiltrated and made inoperable the anterior fascicle. Let's look at this one. Lead 1 is mostly negative, so electricity is going right. Lead 2 has some positive deflections, and lead AVL is wholly negative, so it looks like it's down and right, in which case lead 3 should be mostly positive, or the most positive, and it is. So this is a right dominant heart, and if we look at a 3D, we see leads V1 and V2 strongly positive, much more so than V5 and V6, so again, a right dominant heart. It doesn't look like there is any conduction blocks, so we're dealing here with right ventricular hypertrophy. Let's look at this one. So lead 1 is mostly positive, so electricity still seems to be going towards the left. 2 strongly positive, AVL is negative, so it's going downwards, and then leads AVF and 3 are strongly positives and quite similar in amplitude, so it looks like electricity is going almost straight down, just slightly deviated towards the left, so still left dominant, but a little bit more rightwards than is usual. But when we look at a 3D, we see that it is right side dominant, so V1, V2, V3 are strongly positive, which is not what we normally see, and this is because there is actually a conduction block. We see the RSR prime of the right bundle branch with a deep kind of inversion, the deep negative deflection, and then a bigger second positive peak, which is pathognomic for the right bundle. And again, you'll see that a right bundle makes it look like there is more muscle mass on the right, but it only affects the leads that look directly at the RV, so V1, V2, and to some degree V3. So again, explanation as to the why. And finally, We look at this EKG, lead 1 is positive, so it's going leftwards. AVL is bigger than 2, so it's going upwards. AVF is almost isoelectric, so again, it's leftwards and just above the horizon. And it's so left dominant, and it's left dominant in the precordials because leads V1, 2, and 3 are strongly negative. V6 is whole positive. And then we have QRS widening, the RSR prime mostly visible in 1 and AVL, the QRS to ST discordance when they're positing in opposite directions relating to each other, and we have those somewhat asymmetrical waves in the precordial leads coming almost straight down, coming back at an angle. So this is a left bundle branch, and again, these are the reasons why. So let's start understanding bradycardias. To understand them well, we have to understand what the inputs in the system are. So again, the signal starts at the SA node, normally goes down to the AV node, gets transmitted to the His-Purkinje system. And left to its own devices, the SA node will fire at a rate between 60 and 100 in an average person. Now, there are two ways in which that can be sped up or slowed down. The first one is the vagus nerve. Vagus nerve is part of the parasympathetic system, and it's modulated by acetylcholine, and it has an inverse relation, which means that the more stimulated the vagus nerve is, the slower the heart rate becomes. Therefore, the way to speed up the heart that's going slow is to cut the vagal tone, which we will do with anticholinergic drugs like atropine. The other way to influence the speed at which the heart is beating is to play with a beta 1 stimulation, which is part of the sympathetic system, and it comes down through the thoracic sympathetic chain from T1 to T4 and innervates the SA and the AV nodes preferentially. Now that system is mostly influenced by norepinephrine and epinephrine, and it has a direct stimulation. So the more we stimulate the beta 1 system, the faster the heart will beat. The nice benefit of stimulating the beta 1 system is that not only do we have an increase in the heart rate, but we also get an increase in the contractility. So those are the two main ways in which we can stimulate a heart to beat faster. Either cut the vagal tone or stimulate the beta 1 system. Now, what is happening on the cellular level is also important to understand. So the first thing that happens is that we have the beta 1 receptors stimulated by norepi, although epinephrine will do it as well. Then in turn activates the sodium-potassium system. So the sodium channels will open, flood down into the cell and create an action potential, which will then get propagated down until it reaches the actual muscle cells, at which point the calcium channels will open, release the calcium in the sarcoplasmic reticulum, which will then attach to the myosin fibers and make them contract. That gives us a number of potential places to interact with this cascade of events to slow down or speed up the heart. So at a beta 1 receptor level, if we want to speed things up, we can give medications that are positive chronotropes and inotropes, so things that positively affect the beta 1 receptors. So we have a choice between norepinephrine, epinephrine, dopamine, or dobutamine. Or if we want to slow things down at this level, we'd give drugs that are inversely related to beta 1 stimulation, so beta blockers. At the level of the sodium channels and the sodium-potassium pump, we can give people things like procainamide, which is a sodium channel blocker, which prevents the sodium from flooding into the cell and therefore creating an action potential. Or we can play on the potassium side of things and give people something like amiodarone, which prevents repolarization. It prevents the outflux of potassium ions and therefore makes the cell more prone to stay dormant and therefore conduct less impulses. Finally, we can play at a level of the calcium channels. So we can give somebody calcium channel blockers, which will prevent the calcium channels from opening and releasing the calcium ions which are needed to actually contract the heart. So now that we know all that, we can figure out what are the common causes of bradycardias. Well, probably the commonest one is actually simply heart attack or old age killing off some part of the pacemaking or conduction system, the SA node, the AV node, or the conducting fascicles. Second cause could be that we have too much parasympathetic vagal tone, either because of medications or because of the environment, so vasovagal syncope is a classic example of that. Third cause would be if the sympathetic beta 1 tone has been blocked, usually by medications. Fourth, if the medications that block some part of that conduction cascade, like calcium channel blockers, or procainamide or amiodarone, have been given and they're preventing that cascade from flowing in its natural progression. And finally, if there is too much potassium in the system, preventing the depolarization of a cell, and rarely too little calcium can cause similar effects, just a little bit more downstream. But again, that's quite rare. We can summarize these main causes in a very useful and simple mnemonic called DIE. So things to look for is drugs like calcium channel blockers, beta blockers, sodium channel blockers like procainamide, or potassium repolarization blockers like amiodarone. Infarct, so any evidence of MI on EKG, history, or blood work. And then electrolytes, specifically looking for potassium and rarely calcium. One thing to understand about bradycardias is that any bradycardia, including sinus bradycardia, can kill a patient, which is in stark contrast to, say, sinus tachycardia, which is considered harmless. The reason why is because the cardiac output equals heart rate times the stroke volume. Therefore, as the heart rate goes down, the cardiac output goes down. The only way that a heart can compensate is by trying to keep the stroke volume up, and it can do so by increasing contractility. But there is a hard limit to how much it can do so. You can give people volume, you can stimulate the beta 1 receptors that increase contractility, but at the end of the day, you can only increase your contractility by about 70% compared to your baseline. Therefore, if your heart rate starts going below whatever your usual is, divided by 1.7, your cardiac output will start to suffer and eventually you will lose perfusion. There are also a couple of other factors which we should start assessing formally when reading EKGs. First one is rate. Now, computers are excellent at figuring out the rate, so you can just look at what the computer is telling you, but I like to develop my own capacity. So the easy way to do so is 300 divided by the number of large squares between the QRSs. So if you have 3 large squares between 2 adjacent QRSs, the rate is 300 divided by 3, so 100. Now, this doesn't work if you have an irregular heart rate like a sinus arrhythmia or atrial fibrillation. So the way to do so is to remember that ECG is a 10-second strip. So what you need to do is simply count the number of QRSs present in the entire EKG and then multiply by 6. And also we should assess the intervals, the PR interval and the QT interval. The short PR interval, less than 120 milliseconds, might speak of presence of pre-excitation, while a long PR interval, so more than 120 milliseconds, which is one large box, will tell us there is a first-degree AV block. And then finally, if we have the QT intervals, which is corrected for the heart rate, if it's approaching 480 or 500 milliseconds, we should start getting a little bit concerned, because if it gets prolonged much more, it can lead to polymorphic VTAC. Let's now go through the various bradycardias, and we're going to start at the top at the SA node and go all the way down to the ventricle. So starting at the top, this is a case of sinus bradycardia originating at the SA node and flowing downwards. You can see it's quite slow, so if we count the number of large squares between 2 adjacent QRSs, it's about 9. So 300 divided by 9, it's about 35. Again, if we count all the QRSs on the rhythm strip, there are 6 of them. Multiplied by 6, it's about 36. So it checks out. It's quite slow. We can look at the intervals and see the P's, which in this particular case are best visible in lead 3, lead V3 as well. The PR interval is quite normal and the QT interval is quite normal. And we do have a P present before every QRS and QRS after every P. So it is sinus. So why do we care about sinus bradycardia? Well, first, it can be dangerous. Again, we said that sinus bradycardia can drop the cardiac output just as much as any other type of bradycardia. What are we going to do? We're always going to check for the 3 common causes: dye, drugs, infarct, and electrolytes. And a lot of the times we will find that all those are fine, and what's happening is simply the system has worn out. The person is too old or under the influence of cholesterol and maybe diabetes and hypertension. The conduction system and the pacemaker system has worn out. So if you do have an elderly patient who's having persistent or episodic sinus bradycardias, they're having 6 sinus syndrome, and this won't go away. And those people actually need a pacemaker. If you do see this in a young, especially endurance athlete, this is perfectly normal and doesn't necessarily indicate any pathology. Also, going from the top, this is a case of slow atrial fibrillation. We are used to thinking of atrial fibrillation in the fast terms, right? Because most of the atrial fibrillation is fast. However, there are 2 conditions in which atrial fibrillation can be slow. One is simply we have given someone too many heart rate slowing medications like beta blockers or calcium channel blockers. And 2 is somebody who is chronically in atrial fibrillation and now has developed essentially a 6 sinus syndrome. So the overall speed of conduction has slowed down. So if we look at this particular EKG, we see there is only 4 QRSs in the entire ECG, so the rate is only 24. There is no discernible P waves. The rate is irregular. Therefore, this is some kind of atrial fibrillation. This might be easier to recognize. It's simply a case of slow atrial flutter. So instead of those irregular wigglies around the baseline, we can see distinct flutter waves. So again, what are we going to do with atrial fibrillation or flutter with slow ventricular response? If it is due to too much calcium channel blockade or beta blockade or any of the other drugs, we have to wait it out, hemodynamically support the patient in the meantime. And otherwise, if it is more episodic or chronic, it is an equivalent of a 6 sinus syndrome, and these folks might need a pacemaker, just like people with episodic or recurrent sinus bradycardia do. Again, going down the conduction system, we're going to leave the SA node and the atria behind, and now we are at the level of the AV node. This produces what's called the junctional rhythms. So AV node, as we mentioned, has 2 jobs. First one is to be the block, the brake in the system that separates the atrial rate from the ventricular rate, but the other role it has is to be the secondary pacemaker if the SA node stops the function properly. So in that case, what will happen is we will still have narrow QRSs. They will usually be slow or slowish. The normal rate at which the AV node beats is somewhere between 40 and 60, but it is subject to the same speeding up or slowing down influences as the SA node. But the main distinction is going to be that there are either no P waves in front of the QRS, or the P wave is retrograde and it's buried somewhere in the ST segment. And here we can look down the rhythm strip, which is lead 2, and we can see that we can't quite see discernible P waves in most of the beats. A few of them down in the middle do look like they have P waves. And if you look at the 5th beat, just behind the QRS, you can see a little retrograde P there. So again, narrow QRS, No P waves or P waves after the QRS. It is junctional bradycardia coming off from the AV node. This will happen either because the SA node has been killed off due to old age, infiltration, or an acute MI, or it has been suppressed by things like drugs or increased vagal tone or recent surgery like CABG or hyperkalemia. And if this is a chronic thing, it has no particular significance. The AV node is capable of speeding up appropriately to cutting of vagal tone or stimulation of beta 1 receptors, so will produce the necessary increases in the cardiac output we need for a daily functioning. All that means is that you're more vulnerable if a subsequent, say, heart attack or infiltration kills off the AV node as well as it did the SA node, and we end up with a complete heart block. Also at the level of the AV node is the first degree AV block. So if you remember, majority of the PR interval is not induced in conduction between the SA node and the AV node, but actually in the slow transmission of those slowly diffusing calcium ions through the AV node itself. So if that pathway gets worn out or blocked, you might get an increase in prolongation in how long that takes. And here you can see that you have actually a very prolonged PR interval. All the P's are right after the ST segment, and then it takes a long time to conduct down to the ventricle, but when it does, the rest of the conduction is working well because it's a narrow QRS. So again, how do we define the first degree AV block? PR interval of more than one large square. It usually means there is a worn out pathway through the AV node. Usually this is chronic, however, it can be acutely induced by an MI or hyperkalemia or hypocalcemia. And most of the time it's clinically insignificant. The only time when it does matter is if you start to develop blockages in the other fascicles, so left anterior fascicular block, left bundle branch, right bundle branch, in which case first degree AV block also counts as a fascicle. So if you do have somebody who, for example, has a syncopal event and has a bifascicular block or a trifascicular block, that would need a pacemaker. And again, the first degree AV block in such situations would count as one fascicle. Going further down, just around the AV node, now we have the case of the second degree type 1 conduction block. So what we see here is that we have the PR interval that lengthens and lengthens and lengthens, and then the QRS is dropped. It is a type of dysfunction at the AV node, again prolonging PR intervals until a QRS drops. Chronic, most of them are chronic, it's not a big deal. There is no hemodynamic effect and there is low risk of progression to complete heart block or asystole. Again, like any other bradycardias, it can acutely be caused by dye, drug, infarct, or electrolytes. And rarely, if you have muscular dystrophy, that can progress to higher grade blocks, but for an average person, it is something to monitor, but not to get too excited about. Then we're going to the second degree type 2 block, which simply means there is a fixed PR interval and then a dropped QRS, in which in this particular case, every second QRS is dropped. And this one is more dangerous. Why? The second degree type 2 is more dangerous because it can, with significant frequency, progress to the third degree AV block, and that needs a pacemaker. Now going below the AV node, we come at the bigeminal rhythm, which is basically a normal QRS followed by a wide ventricular QRS. We don't really understand bigeminal rhythm well. Something has irritated the ventricle and it has made it respond. And in this particular case, it is happening after each and every normal QRS. So the easiest way to think about it is just a regular appearance of a PVC in a fixed ratio to the QRSs. Again, normal QRS followed by a PVC or a wide QRS. It is mostly harmless. There is a long list of medications that can cause and a long list of conditions that can cause bigeminy. But most of the time it is not a dangerous rhythm. It is something that for most part can be acute due to example, somebody starting codeine or another of these offensive medications. Occasionally it can be chronic, but it doesn't tend to have hemodynamic effects, and it's again something we monitor, but we don't usually need to do much acutely about. And finally, the granddaddy of them all, the third degree AV block. Now, what characterizes the AV block is the slow heart rate, usually between 20 to 40, the lack of relationship between the P's and the QRS's, and finally, the widening of the QRS. Why? Because this is a ventricular escape beat. As we mentioned, there are three levels of automaticity in the heart. The top is the SA node, then the AV node, and finally, if both of those stop providing meaningful input, the ventricular myocytes themselves will provide their own beat at a rate of 20 to 40 as an escape rhythm to prevent death. And that's exactly what's happening here. Is for whatever reason the ventricles have stopped responding appropriately to the signals from the SA and the AV nodes, and they have gone into their own escape rhythm. Why do we care about the complete or third degree AV block? Again, most of them are going to be acute because this is a hard rhythm to sustain for a long time. We're going to do what we always do. We're going to check dye, drug, infarct, electrolyte. And we're going to put pacer pads on these people even if they have a good degree of perfusion, because the main concerns with third degree AV block is that they can progress to asystole. These people need a pacemaker. Also at the level of the ventricle, this is an example of a sinus bradycardia with a left bundle branch block. So if you look at, for example, lead V6, you can see there is a P wave before the QRS, lead V3 as well. And if you're paying attention to the four characteristics of the left bundle branch block, you'll see that they're all present here. It's a left dominant axis in both 2D and 3D. There is the RSR prime or a squiggle on top of the QRS. There is QRS to ST discordance, and there are asymmetrical QRSs in the precordial leads. And this is just a reminder that you can still have all those other conduction blocks like LBB and LAFB and RBB in the presence of a bradycardia, and that shouldn't affect your interpretation of the rhythm. This is still sinus bradycardia, it's just also in the presence of a left bundle branch block. The main thing here to do is to ignore the left bundle and deal with the underlying rhythm. And again, we're going to check drugs, infarct electrolytes, and anything that has widening of the QRS, we're going to pay particular attention to potassium. We will discuss later about whether a new left bundle is an equivalent to a STEMI and how to diagnose acute ischemia in the presence of a left bundle. Finally, we're left with hyperkalemia. This is an example of hyperkalemia. Now you will notice that it's actually not particularly slow, and most hyperkalemias are not at first slow, but they almost all end up being slow. What you will also notice is the QRSs are wide, but if you go through our checklist for the left bundles, you'll see that it doesn't quite fit the bill. So anytime that you see a wide QRS that is slow and it doesn't look like a left bundle, start thinking about hyperkalemia. You'll also notice that the T waves are really tall, especially in the precordial leads, and that there are no P waves. So this is the classical progression of hyperkalemia. think about two strings. One that is pulling upwards and it's making the T waves taller, and the second one that's pulling horizontally and kind of unspooling the whole QRS-ST segment on the horizontal axis, making it lose the P waves first, then widening the QRS segment, and then finally causing a sine wave and then asystole. Right? So what we see first is peaking or increasing tallness of the T segments, then the loss of the P waves, then the widening of the QRS, and then the sine wave and slowing down and progression to asystole. So when are we going to suspect hyperkalemia? We're going to really suspect it in any bradycardia because it's part of DIE, drugs, infarct, electrolytes. But specifically, we're going to suspect it, obviously, if the clinical diagnosis is there. But if on the EKG we see it wide and slow QRS without left bundle branch block features, and if we see slow rate with tall T waves. So here is a useful little summary for bradycardias. If you see the number of P's equal the number of QRS's and they map 1 to 1, this is sinus. If you see more P's than QRS's, this is a second degree or third degree AV block. If you don't see any P's, it is slow atrial fibrillation if it's irregular, and if it's regular, then it is a junctional rhythm. And finally, suspect hyperkalemia if it's wide but too slow to be ventricular tachycardia and it doesn't look like a left bundle branch block. So the parting shots for bradycardias is to remember that all bradycardias, including sinus bradycardia, can kill. Check drugs, infarct, and electrolytes in all your bradycardias. And then second degree type 2 and third degree AV blocks are automatic indications for pacemakers, whereas for the other types of bradycardias, it is more situational. If people are recurrent or persistent or symptomatic, they might need a pacemaker, even if they're a simple sinus bradycardia. All right, that's all you need to know here. We will see you in the tachycardia segment. Thanks for listening.